Today we're going to talk about osteoporosis treatments. This topic was requested by one of our newsletter subscribers. At this point, I'm going to assume you've made the decision with your medical provider to treat or prevent osteoporosis with medications. So in this video, we're going to look at the types of treatment options for osteoporosis. We're going to look at the pros and cons of each treatment option, and then I'll add some things to consider as we review the options. If you are at the point where you're choosing medications, then you probably fit in one of these three categories. And you're probably a postmenopausal woman, although more and more studies are coming out that men, especially in their 70s or older, are at risk for osteoporosis as well. Groups that are not covered in this session that might also take bisphosphonates are people that are on long-term steroids or undergoing cancer treatment. So those particular situations are not covered in the context of the benefits and risks that I talk about with these medications. For the most part, if you've had a hip fracture or a spine fracture, then you're probably considering treatment. If you've had a bone mineral density or DEXA scan that shows your T-score is less than 2.5, then less than minus 2.5, then you probably are also considering treatment. And then those that have a risk that is less clear might also do something called a FRAX score. And again, I'll go over those in another video in more detail. But for the most part, if you're in these treatment categories, then this video would apply to you. For the most part, we have two different types of treatments that we use for osteoporosis. The first is decreasing bone breakdown or anti-resorptive agents. The second is increasing bone building or anabolic agents. Something I want you to keep in mind is that the process of breaking down and building bone is constantly happening in your body because the calcium in your bones, it needs to be released so that your muscles and your heart and your brain can use them. And so your body has it under tight regulation. But what they've seen is that over time and with age, the process of breaking down your bones tends to exceed or happen more than your building up of bones. In normal physiology, it takes about 3 weeks to break down the same amount of bone that it takes to build over 3 months. And so that's why prevention can be very important with these agents. You can see the classes on the left that we're going to cover with decreasing bone breakdown. Those tend to be first-line agents. And then if you don't tolerate or you have more severe illnesses, then you start thinking about using the bone building agents. Something to keep in mind as well is that with all of these have been studied in the context of people who have had adequate calcium and vitamin D as well. And so that's an important part of your treatment and prevention regimen. We're going to start with the bisphosphonates. Here we have 4 agents, and I've listed their generic names for you, and then the brand names are in parentheses. They are first-line agents because in studies, they have reduced the risk of fractures in your hip and your spine. So you're less likely than those that don't take these agents to have breaking bones in your hip and spine, which can lead to significant declines in mobility. They can lead to disability and pain. How do they differ from one another? Some of the big things that make them different are the dose that they are given, how often or the frequency that they are taken, and then the route that you give them, whether it's an oral tablet or an IV preparation. With alendronate, that is available as a weekly tablet that you take. Risedronate is also available as a weekly tablet. They used to be available and taken daily, but what they saw was a lot of people had esophageal irritation when taking it daily. So by taking it less frequently, more people get less of that esophagitis or esophagus irritation. They also still see that you have benefit for reducing fractures. So it wasn't necessarily that you had to take it every day. The ibandronate is a tablet that you can take monthly. So there's a trade-off here. A lot of people find that while monthly might sound desirable, it's hard to get into a routine. And so in the past, the manufacturers used to have a program where they would call you up and say, hey, this is your day of the month to take this medication. I don't know if they still have that kind of a program or not, but with a lot of alarms and good support, you can have others remind you if you need to, if that's the option that you choose. Also, ibandronate and zoledronate are available as IV infusions, one every 3 months and then the other once a year. Typically, infusions with the zoledronate take about 15 minutes, and then they typically have you stay afterwards for a little while just to make sure that how your body's reacting to the medication, that you're safe or have access to medical services. If in the rare emergency you need it, you have it. One advantage of these first-line agents is that they are generically available, and so the costs are going to be a lot less than the newer agents that are out. For the most part, these are really well tolerated given the lower frequency of taking them and then through proper administration. So one of the things that they've seen is that if you take the medication and then lay down within 30 minutes of taking it, then you're more likely to have that pill have more contact with your esophagus, and then it can damage that. So one of the ways that you have to take this is you have to be able to sit upright for at least 30 minutes after you take it. That is to try to avoid, again, reduce the risk of getting that esophagitis. And one nuance is that with ibandronate in particular, that oral tablet, the by-mouth tablet, you actually have to sit up for 60 minutes after taking that one. So that's just a little different than the other two. One of the things that's relatively new is that after 5 years, you may be eligible for a drug holiday. That is, you may be eligible to stop the medication until or unless your risk goes back up. They got this idea from the FLEX study, F-L-E-X. And basically what they did was they took two groups of people and they started them on a bisphosphonate, a medication in this class. Then after 5 years, half the group stayed on that medication, the other half stopped the medication. And what they saw at the end of 10 years is that whether you took it for the medication for the full 10 years or only 5, you had the same rate of decreasing bone breaks. And so with that in mind, and with in mind the fact that these types of medications stay in your body a long time, those two combinations basically led to the recommendation that after 5 years, you could consider stopping the medication and then just reevaluating your risk if you need to. That also reduces the risk of some of these rare but serious side effects, such as osteoporosis of the jaw, And we'll talk in other videos in more depth about the risk factors for these, but it's very, very rare. But some people, especially if they have dental procedures, may have some damage to their bones. Also, atypical fractures, so fractures that are not common to osteoporosis but break in a different way. Typically, they have to do like an x-ray to kind of see those types of things. Those are also extremely rare. And again, by limiting your exposure to 5 years, then you reduce that risk as well. And with the IV preparations also, you might have some fever or flushing, redness or swelling at the place where they put your IV in. Those, again, tend to be less common and go away after your infusions are completely done. Maybe it might take a day or two, but it would disappear. The next class we're going to talk about is a rank L blocker. Denosumab is the only one so far in this class, but because they've done the studies to look at hip fractures and spine, and the studies have shown that it can be beneficial for both of those, it is also considered a first-line agent. Typically, it's given as a shot in the arm, your upper thigh, or abdomen, and that's done twice a year. That can be very appealing, certainly, for people to not have to do something weekly, but only twice a year. Typically, you get immunizations and vaccinations once a year, and so sometimes you can double up on that. What are some of the downsides? Certainly, that you may need to do it in a specific doctor's office, and they may want to observe you after the shot to make sure nothing more serious happens. Typically, it's like a half hour. The link I have for you there in the proleafinder.com, because there is an REMS or REMS, which I'm skipping down now, that's a risk evaluation and mitigation strategy that is put out by the FDA. So they have looked at it, and because there's a rare but serious event that can happen in people, that they want to make sure that you have qualified practitioners that are going to pay attention to that. And so that proleafinder.com has people who give and dispense those medications as well. So if you're looking at a pharmacy that gives those pursuant to a legal prescription, then you can find them on that website as well. Certainly, because it is a biological, it's an antibody, that it's going to cost a lot more at this point than your bisphosphonates. And that's sort of one of the downsides, certainly, to this particular agent. It can be as much as 3 or 4 times as much as the other one, the bisphosphonates, that is. And certainly, part of the REMS is that you may be asked to do blood work to make sure that your kidney function is good enough to receive the agent, and that you're not at significant risk of having low blood levels of calcium. And of course, if you already have low blood levels of calcium, that needs to be restored before you receive your shot of denosumab. Otherwise, you risk going even lower with your calcium. And then with this particular agent, there might be other serious things, but they're extremely rare, and that is your phosphate might go low, and you might have reactions when you get your shots. Moving on to estrogen and estrogen-like agents, the only reason I include this is because they can be beneficial for reducing hip fractures and spine fractures. However, because of their cons, they're typically not used unless you also have severe hot flashes. And by severe, I mean you're probably nightly soaking your bed sheets, that type of level of hot flashes. They are tablets that are taken once a month. And as I mentioned, they have lots of downsides. So the downside is really a risk of clotting. If you've had a history of a stroke or a DVT, this is really not a good option for you. And then with the raloxifene and basidoxifene, they really haven't been shown to be helpful for hip fractures, only the spine fractures. With the particular brand of Duo-V, it comes in combination with an estrogen, which might be a little over the top unless, again, you have really, really severe hot flashes. But it does also come in in formulations that don't have the estrogen. So this is a very, very specific subgroup of osteoporosis that might receive it, and that is if you have hot flashes and or do not tolerate the other medications and have hot flashes. Bone builders, parathyroid, so that's a gland around your thyroid that regulates your blood levels of calcium. And so it can be important, certainly, in the health of your bones. In particular, they build bones. These agents build your bones. And they're typically reserved, though, for very, very severe osteoporosis, which would be if your T-scores were less than -3, or you've taken the other medications and you still have bone breaks with that. And you're taking them the right way and all the time. The downsides are, of course, because these are, again, biological agents, the cost tends to be higher. With these, they are shots in the arm, but they are daily shots. In mice, they saw the development of osteosarcoma, which led to the labeling of limiting this to 2 years. They haven't really seen that so far that I'm aware of in people, but there still is the warning that 2 years is the max that you should use these. And then, of course, once you stop these agents, you will probably need to start a bisphosphonate or denosumab because your bone density is going to start dropping. With abaloparatide in particular, which is one of these parathyroid-like meds, they've seen palpitations in people, but they're extremely low risk and not that many people. It's enough to mention, but not to really worry about. So if you have, though, atrial fibrillation already or some heart abnormality with your rhythms, then you might want to be cautious as you approach this and consider potentially the teriparatide over the abaloparatide. Also, some people have noticed drops in blood pressure when they first start these agents. That's not something that you would see continued if you didn't have that with those and you keep taking it. Finally, we have the sclerostin blockers, and there's one, romosozumab, which you can see with the AB at the end. This is also a biologic, an antibody, and that helps build bones in your body. It's taken as 2 injections or 2 shots every month. Because it is a biologic and it's newer, the cost is going to be higher as well. This also is required to be given by a healthcare practitioner. If you have heart attacks or strokes in the past year, you might want to delay taking these, although it's quite rare that people have problems, but those who've had previous problems would be at higher risk. Side effects include things like the injection site being a little bit red or swollen. You might feel some joint pain or headaches. If you have really, really low kidney function, you also need to be careful for dropping your blood levels of calcium too low as well. Those are pretty rare things, but because these are antibodies, it's not clear whether people have developed antibodies to the antibody and thus making them not work well. It's extremely rare, but that certainly is one particular disadvantage of antibody. And then what they've seen is that after a year's use, that it begins to start losing some of its benefit. And so even if you take this, you're only looking at a year's therapy with it, and then you would have to switch to a bisphosphonate or the denosumab. One of the agents I didn't cover, which you'll see in here in the bone resorption column, is miacalcin. It's a nose spray. Most of its benefit has been for reducing spine fractures. It may have some pain-killing benefits as well, but it's unclear and thought to potentially have a tolerance effect, meaning it doesn't work as well over time. And so because of that, I hadn't spent a whole lot of time on it, but that's sort of your nuts and bolts with that one. And so you can see here, there's two main classes. The bone resorptions are probably where you're going to start, unless you're very, very severe or have still breaking bones on the bone resorptive agents. Some of the differences between them are how often you take them. It's going to be weekly or monthly, or do you want every 6 months or once a year as an infusion or a shot? And then, of course, the dosage form there, whether you prefer tablets or shots, or nose spray for the only one miacalcin, and then IV infusions. And then cost will also be an issue. You also can check with your insurance companies to see if they are, how much of it they would be covering, and what types of authorizations need to happen. Keep in mind that even though you're at this point, you should still be working on reducing your risk factors for osteoporosis. Things like being active, reducing cigarette or smoke consumption, reducing alcohol intake, getting necessary sunshine as well. And then you may also want your medications reviewed, as there are some medications that can reduce bone mineral density as well. I hope you found that interesting. Let me know in the comments if you have further questions that need to be clarified. You can certainly put them in the comments or send me an email or give me a call. I have that information in the section below the video. Thank you.